So I just wanted to take a few seconds to want everybody to recognize and focus on the bottom of the slide where the arrows is pointing. Knowledge is the best defense against prostate cancer. So I want to reiterate that, and I want people to recognize that. And the second thing, Dr. Carter mentioned that had over 2 decades of experience in the life sciences space. And some people would say that is amazing. But what I say is amazing is the founder of Finn is a 20-year survivor. Now, that's amazing. 2020, 20. So, this evening, what I would like to talk about is something that's very important. The objective is the more you understand your disease, the better decisions that you can make. Because at the end of the day, we can't tell you what to do, but we can help you map out your prostate cancer journey. What's important to you? Quality of life. And depending on decisions you make can influence certain areas that are important to you. So this new publication that has come out, I've simplified it. Comparing side effects for localized prostate cancer treatments. That's what this next journal is about. So this evening, I'm going to introduce you to the report. We're going to review some of the terms in the report, and we're going to talk about the findings. And then at the end of it, what does this really mean for you? And that's what you want to know. So this publication, published in JAMA, patient-reported outcomes through 5 years of active surveillance surgery, brachytherapy, external beam radiation with or without androgen deprivation therapy for localized prostate cancer. What does that really mean? And the first couple of words, everybody's kind of glossed over. Whether you're in the healthcare professional or a survivor, new patient, you don't understand what that means. And that's what we're here to do, is take information that is important for you to understand and break it down so you can effectively communicate with your healthcare providers. So this publication did come out of a group between a wide variety of investigators, but the primary investigator is Dr. Hoffman out of Houston at the MD Anderson Hospital. And there are groups in Vanderbilt that also participated in this publication. So what I said before is, what are important terms to know? Localized prostate cancer, everybody has an idea what that is. So you can either have prostate cancer that's localized that's in the tissue, the prostate cancer tissue, or it could have moved to other parts of the body. We spoke about cancer that's moved to other parts of the body being metastasized cancer. But today we're focusing on localized. Now, also you've heard, whether it's in a lot of presentations here, or if you've spoken with some of the healthcare providers, people use the word cohort. The average person really doesn't understand what a cohort is. But when you hear that, think just a group of individuals, a group of prostate cancer survivors, a group of individuals who are recently diagnosed with prostate cancer. Black folks, that's a group, that's a cohort. And then they'll throw terms in like prospective study. What, what does that mean? And all it is saying is this. I'm going to take a group of people, a cohort, a group of people who have prostate cancer, who are about to take and receive a therapy over a 2-year period. And then, depending on what they select, I'm just going to watch them for 5 years and see what happens and collect this information and summarize it and tell everybody about it. That's what this is about. Titles can be complicated, but the message has always got to be simple. So now in this article, we talked about localized disease, and then there is a group of people who have favorable risk disease versus unfavorable risk disease. Just two simple groups. And these groups can be divided up into the favorable group. They either look at your stages, and I don't know if a lot of people are familiar with just the terms, their stages, which if you have a T1 to a T2B, if you have a PSA level that's less than 20, if you have a grade that's between 1 and 2, that's a favorable state, favorable risk disease. An unfavorable risk disease is a disease where your stage is a T2 and above. You have a PSA between 20 and 50, and your grade is between 3 and 5. Now, a lot of people not familiar with grades, but they are familiar with a Gleason score. So the favorable is a Gleason score between 6 and 7, and then an unfavorable is a Gleason score between 7 and 10. And it's almost as if you split the 7. There's a favorable component of 7 and then an unfavorable component. But just for these purposes, localized disease, you are either at a favorable risk or an unfavorable risk. And I take it a little step further, just so people who may be familiar with Gleason score in relationship to the grade group. So I spoke earlier, favorable risk, you can either be in group 1 and 2, and that's either a Gleason 6 or a Gleason 7, or a 3+4 in this case, but groups 1 and 2. Unfavorable risk, which are groups 3, 4, and 5, which represents a more advanced form of Gleason, Gleason 8, 9, and 10. So, localized disease, 2 groups, favorable and unfavorable. So, now, when people throw around the terms contemporary, let's just say these are the therapies that exist today that the average prostate cancer patient who has localized disease has options for. So in this case, I like to use acronyms, but contemporary treatments, you can have external beam therapy, radiation therapy with ADT, antigen deprivation therapy. You can have nerve-sparing prostate surgery. You can have external beam radiation therapy by itself. You can have active surveillance, or you can have low-dose brachytherapy, and people familiar with just the term SEEDS. But in this case, when you're thinking about these current therapies that you have access to, that you'll be introduced to, especially if you're newly diagnosed and you have a localized disease, just think of E-Neo. Now, then, because we're always concerned about if you have treatments, what are the adverse events? So, in this case, localized disease, whether it's favorable or unfavorable, the types of side effects that you may be exposed to would be hormonal, bowel function problems, urinary problems, whether that's incontinence or whether or not these urges that you have to go to the bathroom or you have painful urination, and then sexual dysfunction. And so I bring up these adverse events because depending on what you classify as your quality of life and what's important to you will determine what type of therapy you'd like to have. And I just happen to use the acronym HBUS, hormonal, bowel function, urinary problems, and then sexual function. So if, when you're speaking with your clinician, you're speaking with a healthcare provider, these are kind of terms that help you remember the questions to ask. So I said before, a prospective study. So in this study that they were talking about, they had 2,008 participants. And they looked at these men between 2011 and 2012 that had a localized disease, whether favorable risk disease or whether it's unfavorable risk disease. And they received these treatments, which we discussed, ENEAL. And then after they received the treatments, we watched them for 5 years. They watched them for 5 years. They collected the data, summarized it, and presented in this report. So, what are our findings? What was the findings of the paper? They kept it very, when you go through the paper, and just to keep it at a high level, something that you understand and feel comfortable with when you're talking to your doctor or your healthcare provider, is favorable risk disease, and they compared the different options against active surveillance, or just say no treatment at all. And what they saw is if they had nerve-sparing robotic surgery, just surgery on the prostate, that had the worst outcome. Urinary incontinence and sexual dysfunction. Now, if you compare low dose rate brachytherapy, SEEDS, against nothing at all, active surveillance, you had worse outcome with urinary irritative problems. Yeah, I got to go to urgency, go into the bathroom a lot, got to go to the restroom at the middle of the night and they have pain. That's that irritative symptoms that you have. Sexual dysfunction at 1 year, bowel function problems at 1 year. Now, what's interesting about the surgery is you had urinary function problems for 5 years straight. Throughout that period that they monitored them, urinary problems. Sexual dysfunction by at least 3 years. Now, lastly, what was very interesting in this report, now remember this is a report from their cohort, or those group of people that were in, that they looked at, that external beam radiation therapy, not clinically different from active surveillance. Urinary function, sexual function, bowel function, very similar to what you would see with active surveillance. So now, there's one point I wanted to say, is that out of all of these conditions, the 5-year survival for all these patients was still 100%. So again, is what do you want to do, and what are you willing, what impacts your quality of life? Now, the next area, they looked at unfavorable risk disease, but instead of active surveillance or comparing it with doing nothing at all, they looked at prostate surgery. And what they said clearly was if you use external beam radiation therapy plus ADT, that there was a decreased hormonal function and bowel function. Now, hormonal function, we talked about it earlier, like your bone health, healthy bones, and this hormonal problem may be related to bone fractures. Bowel function may be related to constipation. So now, the hormonal problem started at about 6 months. The bowel problem started about 1 year out. But one thing, people who receive external beam radiation therapy plus ADT, they had better sexual function and better and less incontinence over a 5-year period. So again, if you're a person who has unfavorable disease and you're at that risk, you'll want to think about what's important to you. Bowel function, hormonal function versus sexual function or incontinence. So there's this complicated title. Now, when you break this information down, really, you're walking away with localized prostate cancer. And people who undergo prosthetic surgery had worse urinary incontinence and sexual dysfunction at 5 years. And that was just the basic take-home message. But then, if we summarize it, what was important to recognize, whether it's urinary, bowel, sexual, hormonal function, all of these differences over 5 years start to decrease. So when you're thinking about the types of options that exist, I give you the acronym ENEAL, but we're talking about external beam radiation therapy plus ADT, nerve-sparing prostate cancer surgery, external beam radiation, active surveillance, or low-dose brachytherapy, SEEBS. Take-home message from this article is if you have a prostatectomy, if you're gonna have prostate surgery, and in this case, this was robotic-based, is what they looked at, you had the worst incontinence over 5 years compared to the other options. And even if you had unfavorable disease, you're gonna have worse incontinence and sexual dysfunction. So the point is, a person diagnosed with localized disease, you're placed into two different buckets, two different categories, favorable versus unfavorable. And then depending on what category you fall in, you have a group of options that you can take. And all of these are dependent upon what you consider to be important. So, the objective of this paper, you see how important this paper is? If I gave you the paper, it's so complicated and full of detail that the simple message is lost. And the paper was important, and we thought it was important because it may just clarify what your expectations are when it comes to the treatment that you'd like to have and how you want to map out your prostate cancer journey, especially as it relates to the quality of life you want to have. So, we put together a simple algorithm. You've heard me talk through it over and over again. We have localized prostate cancer versus metastatic disease. Today, we're not talking about metastatic disease. We're talking about localized. This localized disease can be broken up into two risk groups, favorable and unfavorable. Now, you know I like my acronyms. So even when you go to the doctor's office, if you think GPS, Gleason and grade, PSA, and stage, that's the information you want to be able to collect. Because sometimes when you get into the healthcare professional's office, you really forget what to ask. And so by giving you these little tips like GPS, you can leave filling in the blank. Now, depending on what you have, if you have favorable disease, is it just external beam radiation therapy, active surveillance, low-dose brachytherapy? Or if you have unfavorable disease, is it external beam therapy with ADT or just surgery? But quality of life is important for all of you. Once you have this information, you're in control at determining what type of quality of life you have. So the acronym for this that kind of governs so you can remember what to think about is, even though Dr. Hoffman, so I'll give her credit for it. So we call it HBUS, which hormones, bowel function, urinary problems, or sexual dysfunction. What's important to you and what could you live with? So now we can take some questions, but I also wanted to thank our partners and sponsors, especially Dana-Farber Cancer Institute, for just allowing this opportunity to kind of share this information with you. Thank you. Questions?
I was kind of confused when I looked at the Gleason score,
Mm-hmm.
where you had one score that was 3 plus 4, 7, and you had another score that was 4 plus 3, 7 on the second group. Can you explain that?
Yeah, I mean, that's, a lot of people get in this space, when you're looking at if a pathologist looks at the tumor, one that looks naturally like the prostate. So in this case, that Gleason 3-4 is that the majority of the cancer looks like the prostate. And the 4 is where the majority of the cancer looks irregular. And that's kind of the way to separate the two. And then that's where you draw the line. And that was a very important ask, because I don't know if you're asking me that now, then, and it's important for your clinicians and doctors to really talk about it. And hopefully us reviewing it gives you a better clarity on groups versus Gleason scores. Because now what people are doing is, a lot of you who are survivors for 10, 15, 20 years remember Gleason, but as the field starts to change and they start throwing groups, this is very important for you to walk away with. What is a group and what is a Gleason, and how do they relate? Next question.
Yes. Does the 6 represent a 3.3? A 3 plus 3? And the Gleason?
Well, in this score, it just represents a greater semblance, and the tissue is less than what you find. It's more normal in appearance. I'm kind of keeping it at a high level. It depends on what the pathologist sees. If the pathologist sees from their experience that the properties of the tissue look more like normal, then it's a lesser grade, or the anomalies or the differences that they see are less, the grade is less. So without getting into parsing the 6s and the 7s, that's why they want to move away from the Gleason to something that you can walk away with. Group 1. If you were Group 1, then you can say, Doc, does that mean I'm a Gleason 6? And really, let's move it across back to, I'm in Group 1 or 2. I'm at a favorable risk. And what are my options? Because instead of going into trying to figure out the tissue architecture, let's bring it back to your take-home message is, you're in a favorable risk. And if you're in a favorable risk, these are what your options are. And then any additional detail, then you could walk and discuss with your clinician. So we lay the foundation. Our videos are online. You can always call and get additional questions answered. Next question.
Dr. Crawford, just one quick comment. There's been a lot of discussion in pathology and with pathological specialists about whether or not to continue to treat Gleason 6s as real cancer. Now, that has not happened yet, but there's a lot of discussion about that, because Gleason 6s are really low-grade tumors for the most part. So if the burden is not that high, they eventually you may see Gleason 6 not being cancer. That's not true yet, but I think it's important to understand that this is really favorable risk stuff. And a lot of Gleason 6 patients, if they have a low tumor burden, do not need any treatment at all.
Yes.
Yes, sir. I'm trying to figure out the Gleason and the favorite and the unfavorite and the PSA. Is that all involved in the same thing? Or now my PSA is 0.23. Is that favorable or unfavorable?
Well, instead of separating it into separate groups, you have to look at what we call that, what was your Gleason, what was your group, what was your PSA level, and what was the staging when they took it, because you can't take just one item. It's collectively, and the question is, let's go back to the top. Are we talking, wait 1 second, are we talking about localized disease? And if we're talking about localized disease, then we start looking at placing one in a category of favorable disease versus unfavorable. But first, we have to go back to the top,
Oh, back to the top.
and
What-
say, one, local metastasis. So we move metastasis off the table, and we're talking about local. Then the local, are you favorable or are you unfavorable risk? Instead of jumping to the PCA, the PSA.
Oh, so you mean go from the beginning when you first develop prostate, as far as that's what you're talking about?
Yeah, you gotta start at the top.
Yeah,
When you're speaking with your healthcare provider, they're not down here in the lower level.
yeah,
They're gonna come back and say, we think you have localized disease, or we think you have metastatic disease. And then, again, since we're focusing on local disease, what category, what risk group can you put me in? Now, I'm in the favorable risk group. Additional different information that you can ask is, what's the Gleason? Because a lot of people, when you ask them, they don't even know what their Gleason score is. They don't know what their group score is. They know what their PSA is.
yeah.
They don't know what the path report states about their tumor. Right?
Well, mine went from a 2 to a 7 to a 0.23. It started when I got my treatment. The PSA was low. It was a 2.
And so, but look at what you're saying. You've already focused back on the PSA.
Yeah,
The first thing is, what was the original diagnosis?
yeah,
Did you have localized disease? So those are the questions. I'm not trying to put you on the spot, but when you're speaking with your clinician, especially those who are recently diagnosed, you're getting hit with the whole, you got cancer. And there's so many questions that you're trying to ask. What we're trying to do is give you some framework
yeah.
to start. Start at the top and work down.
Okay.
Don't start at the bottom and try to claw your way up to the top.
Yeah,
Start, and that way you can kind of wrap your way around it. It's less about what the scores are. The general term is favorable disease.
okay, so I gotta ask the doctor, is it favorable or unfavorable?
Yeah, I mean, but again, yes.
All right.
Start out at a very general level to understand your disease. They got to tell you if it's metastasized or whether or not it's local. They got to tell you, well, here's the biopsy. We looked at the Gleason score, or your group is this. Your PSA level is 0.1, or somewhere under 20 if we're talking about favorable.
Yeah,
And then what's your stage after they've taken a piece of the tumor and looked at it? So all of these components are important, and we can't tell you, but we can organize the information so when you walk into the doctor's office, you feel more in control
right,
and less out of control. And you guys can sit down and figure out, hey, I have favorable disease. I have 5 options I can take. What's important to me is urinary incontinence, not having it. Sexual function, that may be more important. But that's what we want to bring you back to, those things that impact your quality of life.
yeah,
That's what you have control over. And this is why papers like this, even though very complicated, we can bring it down to a level where when you walk into a doctor's office, when you walk into your your physician's office, your healthcare provider's office, you can really say, hey, you can ask the questions.
Thank you.
I have a quick question for you. How high was your Gleason, your PSA when you got diagnosed? How high did it
I
go?
think it was 12.
12. And then what treatment options were you offered?
Radiation. I
And,
got the radiation,
Okay.
and I got the neutron shots.
Okay.
I've been taking that for 2 years.
okay. So you've been under treatment for 2 years,
Yeah.
and your PSA, and the last PSA you got was when?
About a month ago.
That was a 0.23.
Yeah.
So you probably bottom out in terms of your PSA at this point with radiation therapy. So from this point on, you need to watch that number. It may not go any lower. It may go higher. You have to keep your
Yeah,
eyes on that.
That's what they said. It
Okay.
might go higher.
Yeah.
They said don't let it go past a 1, go higher than a 1 or whatever.
Yeah. Well, they keep
Then
the
I
eyes
gotta
on it.
be
Yeah,
treated.
they keep them monitor that.
Yeah,
Okay.
but they told me not to worry about it at a 0.23.
No, it's not going to do much right now. Just keep your eyes on it. That's all.
Yeah.
Okay.
Well, I got to see them in 6 more weeks.
Mm-hmm.
They wanted me to go back in 3 months. But I told them I want to be checked out
Okay.
in 6 weeks to see if it went up.
Sure. Keep your eyes on it. That's good.
Yeah.
But don't be upset if you go back and it's 0.24. That doesn't mean anything. It's still 0.23. Okay. Minor numbers don't mean very much. Small numbers don't mean very much when it comes to that.
What, the high numbers mean something?
No, small. Yeah, the numbers go up, but if you have a change of small numbers from 0.23 to 0.27, that's pretty not clinically significant. Okay.
Okay.
One question. When were you diagnosed?
2018.
2018. Okay.
Yeah, and, I have all the dysfunctions that you spoke about, so, hot flashes and all that. But, I'm learning how to live with it,
Yeah, yeah. And it's important for everyone, for you to share your story of what you've learned to not only to the group here, but to the audience that's out there.
Yeah. But, the question I would like to know, now, once I finish the, neutron shot, which would be in June, now after that, I'll be done with all my treatment. Then after that, they watch me for 5 years to see if anything gonna come back or any changes?
So the point that Dr. Carter was talking about is you keeping an eye on your PSA,
Yeah,
okay? And if you have no changes, you have no changes. But as he said before, if you see some big movement in your PSA, that's when you're in communication, you're constantly in communication with your healthcare provider, your doc.
yeah.
And so you start to develop this relationship with your doc, which is important.
Yeah, I do.
Okay. Yes, sir.
I would like to ask you, what's favorable now? I had a PSA of 12.8 and a Gleason score of 9. That's favorable, unfavorable?
Get a
You're
Gleason.
still here, so it's favorable.
Oh, yeah. I just want to know, yeah, what category was that in?
So, but let me go back again. So let's go back to the top. Did you have metastatic disease?
I don't know.
Or did you have local disease? Because what we're talking,
You mean,
localized. Was it,
no, it had come outside of the prostate.
okay, so the topic that we're talking about is those cancers or people who are diagnosed and they're diagnosed with a cancerous state in the prostate. Now, you're saying that you have a Gleason of 9,
Yeah.
but I want the audience to hear, when were you diagnosed?
Where was I?
No, when?
About 9 years ago.
9 years ago.
Yeah.
So I want to bring that up, even though it was a Gleason of 9.
And I had
You're a survivor.
and I was treated with Lupron and after the Lupron shots of Lupron, they gave me radiation.
And something to help your bones, protect.
Oh,
your-
yeah, well, I take
Yeah,
calcium pills and like that.
So in other words, it came out of the prostate, that's what he?
yeah, in his state,
Yeah.
in his condition, when he was diagnosed, it was classified as metastatic disease, where the cancer is not restricted to just the prostate, that little walnut-like tissue.
Yeah, that's what they talked about me too.
So in your case, they said it has moved out,
Came out a little bit.
came out a little bit.
Yeah.
Okay, so was it a little bit in the nodes? You hear those terms? Or was it in a different part of the body in different bones or different tissue?
I think in the bone, I'm not sure.
Okay, and so just to be clear, and this is a very important point, where everybody understands, we have disease that's localized, that stays within inside
Yeah.
the prostate cancer tissue, organ, and then we have those people who are diagnosed where the cancer has moved outside and may be in some of the tissue that's outside this
I
prostate,
think that's what I got.
or in tissue such as your bone. The bone is a tissue.
Yeah, mine had moved into my some of my lymph nodes. Yeah.
So, and that's where I said that when we were talking about today, we were talking about only those people that were diagnosed with localized disease. No nodes, no other bone involvement. But it does give you an idea of important bits of information you need to have when you go speak to your doctor. Because you're still talking about, doc, how is this gonna impact my quality of life? Or what's important to you? But you gotta know what's important to you to have that discussion. Yes, sir.
Not so much a question, but a comment. The information you're giving is very important, but in my case, I wished I had this information before I decided on the procedure that I was going to follow. Because, and I guess, how do we get it to the people then? Because based upon that, I might have had a totally different way of how to treat my cancer. I needed this information from the day I got that diagnosis. Because when you get it and they tell you have cancer, you don't know anything like this. You just make a decision on how you're gonna move forward. So I guess the question comment I have is, how do we reach people before they make those decisions? Because that primary person didn't give me this type of clarity that you're giving me here today.
Okay, so let me just comment on that.
Yeah,
So-
I don't surgery.
The way that information gets out is what we did today. This paper that just came out last month, a month ago. And Tom and I identified this particular article as something that everyone throughout the nation needs to understand. And if it would have come out earlier, we would have had it out earlier. But the moment we see things that impact men, African-American men, and all men who have prostate cancer, we're on the bullhorn and trying to tell everyone about it. I can't tell you what to do, but I can at least be in a position where, and we're sorry we didn't have this opportunity to kind of give you this information, but other men that are listening today, now think about this. Rough numbers, every day, 100 Black men are diagnosed with prostate cancer. Somewhere between 20 and 25 die every day. So our objective is to make sure we find something that's impactful for men who have prostate cancer. We will do our best to get that message out. Newsletters, webcasts, tweets. Sir?
Doctor, can I ask you a couple of questions? What's your overall impression of a robotic surgery?
Personally, I can't give an impression of it. but I can only talk about it in relationship to this. It depends on what's important to you.
Once
That's
a-
my impression. My impression is, what quality of life would you like?
Yeah, I hear you.
So, if you got localized disease, in your 5-year survival is 100%, and you have all these diseases, now if it's favorable, would you really think about surgery?
Okay, and if you
But
did,
again, I'm not telling you what to do.
yeah, I understand.
I'm giving you the information so you think about it. So the people that are online think about it. So they're informed. And they can always go back, either call or look at what we have online. Because I've tried to break it down so people understand it easily.
So after you have the prostatectomy, as I did, I had robotic surgery. How much attention should you pay to post surgery?
So
In
those
terms-
questions from the standpoint of post-operative care,
Right.
those questions have to go back to I can't answer those for you. I can't answer them for your surgeon. So a lot of this has to go back to your physician and help, and then get more information about how it impacts your life. What do you need to do? Because we can tell you how to think about it and how to organize the facts and prepare you to go back to your doc and ask the most important questions, how this is impacting the quality of your life, and what do you need to do to improve it. Robbie first, and then guys.
I want to make a comment in regards to an earlier question about what you should do and those kinds of things. Let me just say, the stuff we're doing right now, you're doing, Doctor, in terms of helping us understand the breakdown of this process. Now, the reason I say that, let me go back. I'm an 18-year survivor. I had the radical surgery. Knowing what I know now, I would have gone in a different direction, you know what I'm saying, had I had this kind of information. But what happens is that there are a lot of things the doctor does not tell you. Not spitefully, what it is that because they're doctors and they all know a lot of this, a lot of the stuff they make assumptions about what they're telling you, and you make decisions based on those assumptions, which says you're gonna go and have the surgery. I'll give you a prime example of what I'm trying to tell you. I had a Gleason score supposedly of a 7. So you know what category that put me in, sort of a high-risk category in terms of the PSA that I had, which was 3.5, okay? But when they did the surgery, they did another biopsy of the prostate, and they discovered that my Gleason score is now at a 6. Had I known that at that time, I would have done something very, very different in terms of my overall process, in terms of what I was doing, you know, for the prostate cancer. So my point is that what we're doing and what the doctor's doing right now is helping those that come after us in terms of what decisions you will make, because I don't think the doctors will automatically tell you a lot of the things that we were looking for. You gotta know something on your own to make the decision, the best decision for you.
Go ahead.
Shouldn't there be an age? Shouldn't there be an age that they automatically give you a PSA exam? This is what I don't understand.
And
Some
I'm
people
gonna
are saying
I'm gonna let the master
50, 60.
of screening kind of give you some background information on that, answer that question.
A good doctor has to catch a flight, but he has to give a talk out west. So thank you very much.
All right, thank you.
In terms of your question about screening and when you should have a PSA, there is data about when you should have that. There's controversy about that, but those of us in this particular area, and those of us who deal with men of color know that you should be screened at baseline at least at age 40. Now, we know that doesn't happen a lot of time, and there's a lot of controversy, and many of the men in this room know about the controversy. We've gone through it up and down about the way the task force looked at screening for prostate cancer. And a lot of work went on by this group over the last decade to get the task force to change the way they view screening high-risk men. So now there's data to suggest that you do screen high-risk men. But there's still a lot of doctors who remember the old information about not screening. And one of our jobs is to try to educate those people about looking out for high-risk men. That is men of color and men with a family history of prostate cancer. They should be screened, educated and screened, given options, of course, and there should be some shared decision-making. We should sit and talk about the risk of having a procedure, of having surgery, of having radiation. And then with that information, we as patients have to make up our minds what we want to do. The doctor's not going to do that for you. So that's very important. But you're right about that. You should get screened, baseline screen for black men and men with family history. In my practice, is at age 40. I don't think anybody looks at black men without getting it by age 45. I frankly think age 40 is a proper age. And for white men or men with low risk, no family history, age 50 is the current
They
recommendation.
treat us the same way. Age
s-
50 and up.
sorry?
Age 50 and up. That's when they start looking at us.
Right, yeah, but what I'm saying to you is that our recommendation, and it's published, has been to screen black men at age 40.
But how come they're not?
Because people look at different data. And the data that came out, 7, 8 years ago was just overwhelming, and it got a lot of press, and a lot of docs start thinking, this is the information that we're gonna go by. And many of them still
People were
believe
dying at
that.
that period of time.
Well, I'm not gonna argue with you about that point, but I think we're on the same side. Yes, sir. Any other questions for anything about, yes, sir?
I saw on the chart there that the people that had gotten a prostatectomy after 5 years, they looked at them for 5 years, and after 3 years, they said that the erectile dysfunction only happened up to 3 years, and yet the urinary problems happened up to 5 years. Does that imply that after 3 years, there's an improvement in sexual function?
For some
Or
men, yeah, for some men.
a slow improvement over the course of the time,
men.
and by 3 years, they didn't stop, they didn't see it anymore, or something
Yeah,
like that.
that is not done sort of de novo, that's done by working at it. For men who have surgery for prostate cancer, most of the surgeons will suggest you get back to sexual activity as soon as possible, and they start giving you pills early on because they want you to sort of get back to having erections. The longer you don't have erections, the less likely you are to have them. So there's always a push to do that. Yes, sir.
Go ahead.
One other question. Is there something that causes us to have it sooner?
We're not quite sure. We're not quite sure.
Wouldn't that be the thing to look for?
Well, people are looking at these things, so.
If you're gonna improve something,
Yeah, people are
You
looking
gotta
at these
know the
things. Like I
source.
say. And a lot of work has gone into this. There was this big deal about genetic predisposition. And that has sort of been downplayed a bit as we look at other potential factors that lead to increased risk for cancers: diet, lifestyle, a delayed diagnosis, a lot of things that impact the outcomes in terms of mortality. But we also looked at, what about the incidence? Why do we get more than other people? And a lot of that also has to do with lifestyle and other things. We talked about, who should get screened and all that. The group going on right now, I'm a part of it, based here, where we're looking at, when to screen and when not to screen, and what are the risk factors. And that data is slow. We got a big meeting on Friday, actually, looking at sort of talking to people in the community and health centers about how they feel about screening and treatment of prostate cancer. So a lot of work going on. It's not that it's not being done. It's just that, we care more about it because we have so much of it. And we put a lot of work in, and we need more people to pay more attention to that. And there was a meeting of one of the task force members at my hospital just a year ago. And keep in mind that this was several years after the task force said that we should not screen anybody. And you remember that, many of you in the room remember that. report came out saying you shouldn't screen, that there's no benefit to screening because there's, when you look at people who got treated and didn't get treated, people who were diagnosed with the PSA, and didn't get the PSA, that the outcomes were about the same. Therefore, why do any kind of screening if the outcome's gonna be the same? Now, many of you know some of that data. But we at Finn worked hard at getting the task force to change that. And those who were in DC a few years ago when we had the head of the U.S. Preventive Service Task Force come and speak, I moderated that session. And 2 years later, there was a change in the grade for screening high-risk men. Now, that's work going into trying to get the government to change its mind about how they look at things. It doesn't happen overnight, it doesn't happen de novo, but you got to work at it. Tom worked at it, this group worked at it, and we had a change, and the new recommendation is that men at high risk should be screened. We went from a D to a C for high-risk men. Now, that's significant. What we have to do is get the word out to doctors who are living in the old ages of the old recommendations. Now, the point I was making about a year ago, we had a gentleman come from the task force, and there was a conversation with one of our urologists who was pro-screening, and he was sort of talking about the task force recommendation. My question to him was, there's a new recommendation of a C for high-risk men. How does the task force get that information out? And he said, well, the usual way, in the journals. I said, but people don't read the journals. I mean, when they said don't screen, it was all over the papers and on national news. But when the recommendation came out to screen, we never heard anything about that. And that is a recommendation now. If you look it up, recommendation C for high-risk men. Discussion and shared decision-making. Have a discussion about it, discuss it with your doctor, whether you want to be screened, and then you make up your mind about it. Not no screening, okay? Totally different than it was in 2012, I guess it was. Okay.
This is in another direction a little bit. You've heard of cluster when you have that examination in your bowels for polyps,
Yeah,
you know,
a colonoscopy.
colonoscopy.
Yes, sir.
Now, I was told by my internist, I've had 2 colonoscopies, and they did have polyps, but they weren't cancerous. But I talked to him about a month, about a month and a half ago. His recommendations is, because of my age, I'm in about almost 85, that I shouldn't pursue that direction of another colonoscopy. So that, I have a brother-in-law, he is 90. His last colonoscopy, he had polyps and they were cancerous. It's a little confusing for me because one way you're trying to do what's right, but on the other side, they say, well, I recommend that you don't get that because of your age and your other little problems that you have. I don't know about us as people of color.
Who do you
But
want
you-
to listen to, you?
I'm sorry.
Who do you want to listen to?
Well, I'll tell you, it plays in a little fun game here. You don't want to go and get it done and find you have polyps with cancer. On the other hand, I'm a more risk taker, but you got a good point, and that's the other side that bothers me.
Well, you know, a lot of decisions about cancer screening are based on population studies. So they look at the total groups of people and they decide that past age X, the likelihood that you're going to get something goes down if you haven't had it in previous studies. And that's how they come up with population screening. So for women with pap smears, now we do them every 3 years. There were women who come in and demand their annual pap smear, even though data shows that if you skip 2 years, you're not going to miss much. And if you do pick it up on the year 3, it's going to be so minor that you'll be able to treat it if you got it. So colonoscopy is a little bit different. And my patients get them at 80. A lot of them don't want to get them anymore. But I encourage that they get screening until the gastroenterologist says it's probably not in their benefit. But I deal with them on an individual basis because that's what I do. Okay, so the data about screening is population-based data, looking at everybody. But I have to look at you in my office as a person and not so much population work. And if you have concerns about colon cancer, then I would recommend you get screened. There is a point at which the preparation for a colonoscopy can be tough on an older person. I'm not talking about an 85-year-old like you who runs 10 miles a day. I'm talking about I'm talking about the ones that are not very active and have other maladies that may make it tough to go through the clean out that's required. I had a patient of mine. It's one little anecdote. She was 104 in November, but 3 years ago she walked in. She said, "Dr. Carter, it's time for my next colonoscopy." And I said, "You had one 5 years ago." She said, "Yes, that's why it's time for my next one." And I said to her, "Well, I think you're going to be okay." I said, "But to put your mind at ease, let me have you get a consultation with the gastroenterologist," which she did. And they said, "Nah, we think you're okay. You don't need it." She was happy as a clam because she got confirmation from somebody who was in the field. But I didn't say, "Nah, you don't need it," and I didn't and stop right there. I gave her the option of doing that, and I think that's what you ought to do about your colonoscopy, regardless of what your primary care doc says. Oh, we're running out of time here, so we got time for one more question. In any area, I don't care. Yes, sir.
I have a sort of a comment and question that ties into the discussion about colonoscopies. My concerns are my own concerns with a prostatectomy. I have another friend who's around 80. He's seriously overweight. He had a prostatectomy as well, and he got external beam radiation. And his long-term problems are very serious because he has numerous bowel perforations continually over a period of time as a result of that. And I don't have those problems because I had a prostatectomy. And I'd much prefer my problems to that problem because that's an ongoing problem for him. And he's 80 years old, and he has to get colonoscopies, not just to check for polyps, but he has to get colonoscopies to get those perforations cauterized, or else he has severe bleeding. And so, it's not that just the 5-year out side effects that are important. It's actually the much longer side effects, depending on who you are and depending on your risk factors, that could be much, much more important. I do not want to face the next 15 or 20 years of bowel perforations. I prefer dealing with incontinence, frankly, or ED. But, to me, the external beam radiation therapy that I could have opted for my Gleason 7 PSA about 5, I could have opted for that, but I'm glad I didn't, knowing this friend of mine who has these severe bowel problems. And that really worries me about the long-term effects, not just 5 years out, but 10 or 15 or 20.
Well, the potential side effects of external beam radiation include radiation proctitis, what your friend has, and radiation cystitis, which means the lining of the bladder gets inflamed. The people who have the cystitis end up with a lot of burning when they urinate, sometimes blood, and that tends to go on and on and on and on. The ones with the proctitis have the same problem, a lot of bleeding and what have you. Sometimes to the point there's a particular person that I've consulted on, not my patient, but he got sent to me, who had the same surgery, ended up having to have a colostomy. That is, had to have an operation. I saw him a week ago. He tells me that he's going to be reconnected, but he was having so much pain he couldn't function from the proctitis. So that is always a risk. Now, fortunately, is not a high risk of getting that, but some guys do end up with that. There's some treatments now that have been put together to sort of block against that. There's some gel inserts that are being inserted. You've been to these meetings and talk about that as a way to sort of stop that particular process. That probably wasn't around when your friend got treated, but that is now. So I have a patient right now who's lining up to get radiation therapy, and the radiation therapist has already spoken to him about that particular insert to try to block the effects of the radiation on other parts of his body. That is a bad side effect.
Yes, I want to comment on that too. What happened to me, I had the colonoscopy too, and I had the radiation. So I talked to my primary care doctor, And I had bleeding in the stool and all that stuff too. And he said, one doctor told me to have the go inside and repair the colonoscopy again. And my primary care doctor told me not to because it can heal itself, you know, and mine's healed itself. I don't even have blood in my stool no more.
Okay.
And I don't have no burning. So if he had went in there and tried to prepare it, would have damaged me more?
But no, you don't know that though, because it didn't get done. So, you know, the hope would have been that it would have helped, but the fact is you were lucky enough that it helped, that it got healed on its own. Can I ask how old you are?
I'll be 60 next month.
Yeah, so you have future colonoscopies ahead of you. So the colonoscopy, you shouldn't avoid those. You should be getting those.
Yeah, I get
to, you know, for colon cancer and not having anything to do with your prostate. Folks, this has been great, but they're going to throw us out of here if we don't end this webcast. So thank you very much. Let me see if I can find, I don't have my slide here, but, you know, we want to see you guys next month. Same time, same channel. It happens to be on the 11th of March, because this is the 11th of February. I think I'm right about that, or 12th, the 12th of March, the 12th of February.
Second Wednesday of the month.
Second Wednesday of the month, every month. And there's a Daddy's Boys coming up in Durham, and I don't have that information right in front of me here. Jerry, when is Daddy's Boys? March 21st in Durham, North Carolina. If you're in that area, neck of the woods, please check out Daddy Boys. It's a wonderful program about education and prostate cancer. It's a wonderful play, and hope you guys catch that. Otherwise, we'll see you here next month. Thank you very much for being here. Those in the listening audience, if you got any questions, please send them to us by email or by Twitter or by Facebook. Thank you very much, and goodbye.